Assalamu alaikum everyone. My name is Asmaa Monsoor. I'm a third year medical student and inshallah I will be giving you the airway mechanics lecture which will cover two of your pulmophysio lectures inshallah. So the first lecture is going to talk about just airway resistance and the second one is going to talk about um, the functions and how to assess different diseases. This is practically it. It's very easy compared to all of the other dense lectures. These lectures are really easy, straightforward, and I will tell you the high yield points, inshallah, that will most likely be asked in the exam. So stay tuned, okay? If you have any other questions, any concerns, anything you want to ask, here's my contact. You can always text me or email me any way you like. Okay, let's start. Wait, let me just get this out of the way. So everyone, let's start with a small dua. Just 30 seconds. I love this dua. It's really so nice. Okay, all right. So as I was talking about, we have two lectures, okay? So the first lecture is going to talk about airflow and the different factors that affect the flow of air in the lungs, the resistance of air, and other things about resistance. I'll talk about that later. And then the part two will be about how to assess the function of the lung and two different diseases, which is obstructive and restrictive diseases and how they're affected, all right? Also, if you have any questions, you can unmute in the middle and ask me or put it in the chat box. And just in case I'm not seeing the chat box by mistake, you can spam the chat box. It's fine. Okay? I really want this to be as interactive as possible. You guys are here and I want you to leave with 100% understanding, inshallah. Okay? All right, let me just get started. So the first lecture is about airflow and resistance. Wait. Yes. Okay. So, what do you guys know about airflow in general? Like, what is airflow? Like, the basic terms. What is it even? Basic. What's airflow? It's the flow of air, right? Like air is flowing inside and outside the lungs. That's literally what airflow means, okay? Now, as doctors, we want to know the little details of airflow as well. What are the details that we want to know? Let me tell you about this. First, we have airflow. What's airflow? It is the amount of air flowing in a given time. For example, you have three different taps with water, but just to give you the concept. So I have these three different taps with water, okay? And I'm switching them all at the same time. I'm switching them on at the same time and I'm freezing them in time. And this is the picture that you can see. So in 1 second, I froze them, and this is the amount of water that's coming out of each. Now tell me, which tap has higher flow? Which tap? The one on the left, the middle, or the right? Which one's having higher flow? Which one? The one on the left, right? The one that is the most left, yeah, that has high flow. Why? Because we're checking two things. First is how much amount of air or water is coming out of the tap. And the second thing is how much time it takes for that water to come outside. So airflow has two more important factors that I want you guys to know. First is the time and which is the speed of the air itself and the volume of air, all right? Now, usually we don't assess the flow of air. However, in history, like previous and olden days, airflow was assessed as part of an examination, and this was assessed by a machine called as pneumotachometer. And this is how it looks like. You have to just blow through this mouthpiece, and it will assess how much air is flowing. Do you need to know what a pneumotachometer is? No, it's not that important. It's not used now, so you don't need to know about it. But just what you need to know is what is airflow. Now, for air to flow from one place to another, you need to have what you call a driving force, so something that is driving the air outside to inside or inside outside. And the main driving force for breathing is the pressure difference between the one that is in the alveoli and the one that is in our mouth. Okay, so because the air comes from the mouth and goes to the alveoli and comes from the alveoli goes to the mouth, right? So now the for checking the pressure in the mouth. Okay, so this PaO that you can see over here is the pressure in the airway opening, which is the mouth. Why such a complicated name? I don't know. Just say pressure in the mouth. I don't know, but it's pressure in the airway opening. All right. So pressure in the airway opening or pressure in the mouth is the same as the pressure in the atmosphere that is written over here, PATM. Okay. The pressure in the atmosphere is same as the pressure in the open mouth. So that's one thing that we already know. That's one parameter we know. The second parameter is the pressure in the alveoli, all right? So pressure in the alveoli, if you want to ideally check the pressure in the alveoli, you need to stick a needle inside the alveoli to check the pressure. Is that possible? No, that's really invasive. We cannot do that. However, there are other methods, estimated methods, like the whole body plethysmography, which is you sit in this box, which is airtight, and you blow through this tube, and suddenly it's going to suck out the air. And when you try to breathe in, it's going to check your alveolar pressure. Yes, that's how it's done. Do you need to know what's a whole body plethysmography, how it's done, etc.? No, you don't need to know. It's just an extra information that you need to know. All you need to know is airflow is driven by pressure difference, okay? The pressure difference is between the alveoli and the atmosphere, all right? That's all you need to know. Is everything good so far? This is literally the basics, guys. Is everything good so far? Are you guys with me? Great. Thumbs up for everyone. All right. Now, coming to the next topic is airflow resistance, okay? Now, airflow resistance, I want to tell you about important things. So the air resistance is the important topic of this first lecture that I'm talking about. I'm talking about two lectures, right? Out of the first lecture, air resistance is the important topic and it's going to come in the exam. For air resistance, as the name suggests, is the resistance that the air has to face while it's traveling from the alveoli to the outside world or from the outside world to the alveoli. What are the obstacles or the resistances it faces? Is given by a formula. Wow, what's this formula? So the R is represents the resistance of AW is the airway resistance. That's it. AW means airway and R means resistance, all right? That's what airway resistance means. It is given by this Hagen-Poey formula. It's actually a French word. I'm not sure how to pronounce it. But this Hagen-Poey's law says that the resistance in the air, the air, how do I put this? Yeah. So the resistance that air faces in the airway is equals the driving force divided by the flow. Okay, so V with a dot on top is called the flow. Okay, this is the flow that I talked about in the previous slides. This. Okay, this is flow. Okay, so pressure difference divided by the flow. This is the resistance, right? You're right. It's also calculated with another cool formula, which has 8 times eta times L divided by pi times r to the power of 4. Do you need to memorize all of this? No, they're not going to give you any questions or numerical based formulas based on this. No, they're not going to give you that. However, from this part, what you need to know is the airway resistance or the resistance that air has in the bronchi is based on all of these parameters. So it's based on the alveolar pressure. Can you change alveolar pressure? Can you change, guys, do you think you can change alveolar pressure, which affects resistance? Can you change how much pressure is there in the alveoli? What do you think? Can you? Can you not? You cannot change the pressure that's in the alveoli. That's kind of an impossibility. You cannot do that, all right? So this says that this part of the equation is, it's not that important because our resistance is not damaged or affected by that. What about atmospheric pressure or the pressure in the airway opening? This pressure can be affected if you are scuba diving or if you're on another planet. All right. So these are the two ways you can change the atmospheric pressure and thus change resistance. Okay, and the airflow as well. Airflow is usually not changed because air just comes in and goes out. But I'll talk to you about this later. Now, talking about this symbol means density. All right, density of the air itself. So, for example, all around Earth, density is the same. However, deep inside the water, the density of the water itself becomes different. For example, scuba divers, they take this oxygen tank with them, right? This oxygen tank, because of the high pressure deep inside the sea, it can become more dense, all right? So this affects the density, and so they have a bit of a hard time breathing. So under the sea, to make the air less dense, you know what they do? They actually add helium, which is so interesting. They add helium to the oxygen so that the oxygen is more light and this decreases the density and it's easier for them to breathe. So cool, right? So that's one thing. So resistance is depending on density. The next thing is length. Length of what? Length of the bronchi. So for example, it has to pass from the mouth till the end of the alveoli. Does this change ever? No, it's not changed ever. So it's just going to be staying fixed. The next or the last parameter that we need to know and is super important for the exam is the radius of the bronchi. The radius of the bronchi and how it affects resistance is super important, especially as you can see, it's radius to the power of 4. So any change in radius is going to incredibly change or affect the resistance as well. All right? So everyone's good so far? Everyone's with me? Yay, great. Okay. So that was just the basics of airway resistance, okay? Now, for the factors affecting resistance, we talked so far, number one was density, right? Density. How they will ask the question for what? Yeah, I will explain you more. Yeah, it's very important to know how they ask the question for the radius. You mean the radius, right? Okay. I'll explain you later because I'll come to that. I'll come to that. Okay. So let's first talk about the factors affecting resistance. This is important as well. Factors affecting resistance is number one we talked about is the density. All right. So the density is affected. The second thing we talked about was the radius. Now, how do you affect the radius? Wait, let me show you guys this. So, how do you affect the radius? So, first we talked about the density of the inspired gas, which changes under, deep inside water, or if you're living on the moon. All right. The second thing was radius. How do you change radius? Is by changing the smooth muscles, either they contract or relax in the bronchi itself, right? So, the bronchi, we know that it has smooth muscles, right? It can either contract or relax. If it contracts, that means the radius is going to become smaller. And if the radius is going to become smaller, what happens to the resistance, guys? What do you think would happen? If the radius is going to become smaller, the resistance is going to increase or decrease? Increase. Yes, you're right. Yes, it increases. Yes, if the if the radius decreases, the resistance will increase. All right. So the opposite happens if the radius increases or the tube or the bronchi is bigger, the resistance is going to decrease. This is basic sense, but yes. So for resistance, for radius, how do we change radius in the human body? There are two main methods, okay, to change radius in the human body. First is the sympathetic and the parasympathetic innervation. So the nerves from the brain, coming from the brain, come to the bronchi, okay, and they affect on the smooth muscles of the bronchi itself, all right. So they release transmitters like epinephrine, norepinephrine to the smooth muscles, which either makes them contract or makes them relax. Okay, I'll come to your question in a bit. Okay, they'll either contract or relax. All right. So if it contracts, the radius decreases and resistance will increase. Yes, and if they relax, radius is going to increase and resistance is going to decrease. Other things are agents or like chemical substances that are there in the body, like histamine, acetylcholine, thromboxane A2, prostaglandins, leukotrienes, etc. All of these substances are like chemical substances that are released mainly whenever there's like allergies or inflammation. All right. So during for inpatients having asthma, for example, these substances are increased. And these substances, when they increase, they act as bronchoconstrictors. Bronchoconstrictors means they contract the smooth muscles, making the tube really narrow and thus increasing resistance. And this affects what? The air flow. Okay? The airflow is affected by resistance, and the resistance here is affected by the radius, which was affected by these chemical substances. And this was in asthmatic patients, all right? So is density same as viscosity? Yes, you could say, yeah. Density and viscosity is the same thing. I think Mariam was asking that. Now, so that was two things, two factors I talked about. The third factor is the amount of carbon dioxide or the partial pressure of carbon dioxide. I'll come to this later. This is important. It's important for the exam as well. I'll come to this later as well. And the last thing is lung volume. So I'll come to this as well later. But for now, density, partial pressure of carbon dioxide, radius of the bronchi, which is affected by sympathetic and parasympathetic and also other chemical substances. And the fourth one was lung volume, all right? Just keep this in mind. Now let's come to the important topic, which is radius, which is super important for the exam. So come on, let's pay attention. Okay. For the radius, okay, they have many terms. For example, you can see over here the radius, right? The radius of this main bronchi, for example, it could be 5 centimeters, all right? Then once it divides, it becomes like 2 centimeters. And then once it divides again, it becomes smaller and smaller, right? So the radius of each single bronchi or each single bronchiole is going to become smaller and smaller. However, we're not talking about the single radius. We're talking about the net radius or the total diameter. For example, if you have one bronchi that's 5 centimeter, the total airway diameter is going to be 5. All right. But if it divides into two segments of the bronchi, and this one segment is 2 centimeters and the other segment is 2 centimeters, then the total airway resistance is going to be 4. 2 plus 2. That's how we calculate the total area diameter, all right? Just to give you an overview. So this is what happens. Now, so we talked about radius as total area diameter, and another name for it is the cross-sectional area. So all of this mean the same thing, okay? Do you have any other questions for that? Was it confusing? The total area diameter and the cross-sectional area. Did you guys get it? Hopefully you guys got it. Okay. Okay, anyways. So we were talking about radius and the three terms. Radius, total area diameter, and the cross-section area. All mean the same thing. Now we're on the same page, right? Now we talked about how to modify the radius. This much time I was talking about how the nerves and the chemical substances will either make the radius contract, sorry, the smooth muscles in the bronchi contract or relax, all right? How do they contract? They contract by using ATP. So it's called an active process. So to modify the radius or the total diameter of the bronchi, you have two methods to do. One is the active method, and this active method is by contracting or relaxing the smooth muscle by epinephrine, norepinephrine, or the sympathetic parasympathetic system, all right? The second method is a passive method. This passive method, okay, let me put this here. Yeah, this passive method is dependent on something called transmural pressure. So this transmural pressure is an important concept, guys, that you need to know. Wait, how do I put this somewhere else? Yeah, it's an important concept that you need to know, guys, because it forms the basis of so many things. So come on, let's talk about transmural pressure now. So trans means across and mural means wall, okay? Yes, Noor, you're right, absolutely. I was coming to that. Yes, you're right. Okay, let me just explain transmural pressure right now. Okay. So now, talking about transmural pressure, it's the pressure across the walls of the bronchi. For example, you can see over here, this is the bronchi's wall, bronchiole. Let me just call it airway, okay? This is the wall of the airway. Now, the wall of the airway has some pressure pulling it inside, which is this black arrow over here, or pulling it outside, which is this black arrow down here, okay? The net force acting on this airway wall is called a transmural pressure. All right, transmural pressure. Now, the transmural pressure is the one that decides if this airway is going to remain open or closed. For example, let's talk about the natural pressures that pull the airway down, which is this pressure. Okay, if it pulls it down, that means the airway is going to open, right? Can you give any examples of what could happen? For example, if I'm taking a deep breath and there's more pressure downwards, which is pulling the bronchi more, which means that there is going to be more, how do I say this? More transmural pressure. Okay, wait, guys, let me explain to you in a different way. Transmural pressure has two parts, okay? Number one is this downward pressure. This downward pressure is not downward, you could say outward pressure, which makes more sense. The outward pressure, which pulls the bronchi apart and thus increases the radius, is number one, the expiratory muscles, the muscles of expiration, which is like which is like the, how do I call it? The inspiration muscles. For example, the diaphragm, the intercostal muscles, etc. Okay, all of these pull it outside. Okay, so that affects the transmural pressure. What about the pressure inside? What do you think? What do you think will affect that? Any ideas? Or what will affect it? It's coming in, so it's going to be the lung recoil. Alveolar pressure. Alveolar pressure is a nice idea. It is a nice idea. It is a very interesting answer. I'll tell you. I'll tell you what it is. Yes. So over here you have inside this alveoli, you have alveolar pressure. And the same pressure is going inside the airways as well, right? So the alveolar pressure and the airway pressure are the same thing. And if you have air inside, it's not going to allow it's not going to allow the bronchi to close, right? So it's going to be part of this arrow, which is the outward pull. It's going to push it in the walls, the air inside or the alveolar pressure, it's going to push in the walls. That's the outward pressure. All right. The inward pressure is by the lung recoil. Um, yes. Yes, you're right, Hussein. So transmural pressure is not only dependent on the air in the airway, it's also dependent on the muscles acting to pull the airway, and it also depends on the lung recoil itself. Okay? I wish I had a better pointer, honestly, but this pointer is so big. Okay, so see, guys, this arrow, which is the pressure that pushes inside the walls, okay, it's going to be the alveolar pressure. From within, it's going to push on the walls, making sure it's patent. It's going to be the alveolar pressure. Whereas the ones that are going to be pulling it out is going to be the muscles of expiration and also the lung recoil. I think I have better places. Oh my God, this is so nice. Okay, wait. Yeah, let me explain it over here, guys. So I was talking about transmural pressure. Transmural pressure, it depends on two things, two important things. One is the purple arrow, and the another one is the green arrow, all right? Now, the purple arrow is the one that is pulling the alveoli and making sure it's patent, all right? When you pull the alveoli, this is done by the expiratory muscles. When you expire, for example, expire in the sense like when you exhale or when you inhale, these are the muscles that keep pulling and making sure that that the airway does not collapse. Whereas for the green arrow, it's the lung recoil. Okay? The lung recoil is the pressure or like the force that makes the lung collapse on itself and becomes like one big mush. Okay? So lung wants to recoil and become this one big mush. However, the airway pressure or the pressure of air inside the tubules itself or inside the bronchi, and the pressure created by the muscles extending the bronchi, both of these will keep it open. So there is this fight between these two pressures, and these two pressures balance each other and make what you call a transmural pressure. Okay? Well, did that make any sense? Did that make any sense or not yet? Do you have any questions? I feel like I confused this concept, guys. Are you guys confused? Okay, so coming back, we have radius, all right? The radius can be changed by two methods. The active method, which is by contracting or relaxing the smooth muscles of the bronchi. The second one is the passive method. The passive method is affected by the transmural pressure. Now, the transmural pressure is the pressure across the bronchi's wall, okay? Two pressures affect the bronchi's wall. Number one is the expiratory muscles, which pull it outwards and keep it open. Number two is the airway pressure, the pressure inside the alveoli, which again pushes it outside and makes it open. All right, which again increases the radius. And the third one is the lung recoil force, which pushes again all the lungs tissue wants to make push inside and make a big mush, and that is the inside force. Balancing all of this, we have the transmural pressure. Now the radius depends on the transmural pressure as well. All right, hope you guys got it. Any questions in this place? Hopefully clear, inshallah. Okay. Now coming back to what Noor was talking about. So I was telling that over here, the when we talk about the resistance and the radius, how radius is important to resistance, we said that as the radius increases, the resistance will decrease. However, the radius we're talking about over here is the total or the net diameter or the resistance, the total resistance that is present in all of the bronchi in a particular area. For example, over here, this bronchi is just one. All right. So we count the diameter or the radius for just this. However, in the periphery, you have so many tiny, tiny bronchi. So we count the diameter or the radius for each one of them. And when we add all of them, we get the total diameter. Okay. We get the total diameter. So when we add all of them, surprisingly, actually, subhanallah, the radius of all of these is more than the radius of the bronchi, even though the bronchi looks giant. Okay? So in that case, this the radius, I mean, the radius over here is bigger than the radius of the bronchi, so the resistance is going to be lower in the periphery compared to the center. All right? So the radius is going to be, so the resistance is going to be very low over here. Why? You would, if you think about it, you don't want so much resistance for air when it's entering the alveoli. You want it to be smooth, relaxed, and like a calm wind. And over here, it has a lot of resistance. So it's very important for us to know one important thing, which is the upper airways, which is the bronchi and the first few branches. They provide more resistance than the lower ones. Why? Because we said the total diameter or the total net diameter of the small, small bronchi or bronchioles is more than the net diameter that we have for the bronchi, the main bronchi. Got it? I'll explain you guys over here in this diagram. So I saw this diagram in your slides. So this slide shows literally the same thing. This, for example, is the dead space or the conducting zone of the alveol of the, what do you call that, of the respiratory tree, and this is the respiratory zone. All right, so the respiratory zone is responsible for gas exchange. However, when you see the net diameter or the volume itself, the volume of air that is in the respiratory zone is 1,000 times or so huge compared to the volume of air that's present in the bronchi. All right, did you guys get this about the volume? We're talking about volume now. So the volume is the amount of volume or the volume of air is more in the respiratory zone compared to the dead space zone. Number one. Okay. Number two is we're going to talk about resistance now. Okay. And resistance is depending on radius. And we said that the radius, the combined radiuses of all of these tiny, tiny bronchioles in the periphery of the lung is more than the radius of the main bronchi itself. So the radius is more over here in the periphery compared to the radius in the center or the main bronchi. So if the radius is more over here in the periphery, what happens to the resistance? The resistance will be low. All right, the resistance will be decreased over here in the periphery. All right, whereas in the center or the upper airways, it's going to be a lot. This is very important, guys. This question is super important. It could be asked in the exam. However, do you need to memorize this diagram? No, you just need to know what is needed, the concept from this picture. The concept from this picture is that in the respiratory zone or in the periphery of the lungs or the bronchial tree, you have increased volume and increased net radius. When you have increased volume and increased net radius, the resistance will be low and the resistance will be low, right? Whereas in the upper airways, you have decreased radius and so the resistance will be high. Okay? This is another diagram which says the same thing, okay? Do you need to memorize the diagram or memorize every single point about it? No. What you need to know is the same thing that I said before. Resistance and where the resistance is maximum. Now, let's talk about this diagram first. Over here, we have, what can you call it? The generations of segments. For example, if this is the main bronchi, the first generation is going to divide into, the second generation is going to divide into, and further on. You guys get it? That's generations, okay? Which is the number of divisions of bronchi. That's what's written over here. So this is the main bronchi, and then it divides, as we go from here 0 to 20, it divides each time. This is like 20 times the division of the main bronchi. That's what it means over here. Over here, it's talking about the resistance, okay? So we're coming from the upper airways to the lower airways. That's what this picture is talking about. What happens to the resistance when you move from the upper airways to the lower airways? Let's see. So when we see the what we can see over here is the resistance increases and then decreases a lot, okay? So from this, we can point out one thing, which is the resistance in the lower airways is so low. Can you see? It's almost like zero. The resistance is super low, right? Whereas the resistance in the upper airways is high. It's like over here. Okay, in this axis, it's like, oops. In this axis, it's over here, all right? So that's one thing that we can get from this slide. The second thing that we can get is this point that why does it increase and then decrease, right? Why it increases, the resistance, why it increases is as you divide, as you become smaller, initially, how can I make over here? Yeah. Initially, you divide the main bronchi into smaller parts. And initially, until like the fourth generation or so, the bronchi divides and the total radius becomes smaller than the previous one. And that is why the resistance becomes high. You get what I mean? Should I draw this for you guys? For example, if you have, guys, if you want me to speed up or go slow, or if you want me to repeat anything, just let me know in the chat box. I'm seeing it, all right? Okay, so for example, this is the main bronchi, and this is the other next bronchi. You will be dividing this so on, okay? Over here, for example, the radius is like 5 centimeter. Over here, the radius is about like 2 centimeter, and over here, the radius is like 1 centimeter, and so on, okay? So taking into account the net radius for some time will decrease. Why? Because the amount of bronchi is becoming less. However, when you start dividing so much and the number of bronchi increases, then in that case, what happens is, let me go here. Then in that case, your radius will become so high and the resistance will decrease. Okay? Do you need to memorize every single part of this? Is no. You just need to know the concept, which is number one. In the lower airways, the resistance is low. Sorry, yeah, and in the upper airways, the resistance is high. And the resistance will increase a bit and then start decreasing because as the bronchi divide, initially the radius becomes smaller until the amount of bronchi is a lot and the total resistance, the total radius is a lot, and the radius and the resistance decreases. So bronchi divides and radius decreases. But because of the large number of bronchioles present in the end, the resistance decreases at the end. Absolutely correct. You got it. You got it perfect, Mariam. You're right. That's what you need to know from this picture. That's all that you need to know. Okay? And over here, as you can see, this is the next diagram. It's it's saying the same thing as the previous one. Over here, you can see the divisions of the bronchi, the 0th division and the 20th division of the bronchi. And you can see the resistance from them. As you can see, the least, because of increased diameter in lower respiratory tract, the resistance decreases. Yes, yes, you're right. Yes, you're right. So when in the lower respiratory tract, the net diameter increases, and when the net diameter increases, the radius will decrease. The only point that is a bit confusing is this part over here, is when the radius, as the bronchi divides, the radius becomes a little smaller at the beginning only, and so you have a high what you call resistance at the beginning itself, only in the beginning. It goes high and then becomes super low. As you divide, it becomes super low. Any questions over here? High airway resistance, yes. Over here, in the upper airways. Why? Because the radius low compared to the lower airways, okay? Now let me just finish this graph, guys. Now this graph over here, as you can see, this is the generations of the bronchi and this is the resistance. The resistance from the, wait, what is the resistance from mouth generation N? Um, this is the diameter of the bronchi below 2 millimeters, and as you can see in this case, well, guys, actually this is confusing. I wouldn't suggest going over this graph. Yeah, let's just stick to this graph. This graph is a bit confusing. It will confuse the concept that we learned already. Let's just skip this graph for now. Okay? Wait, let me just. In the second graph, the resistance is increasing, maybe because it's still in the beginning. Yes, the second graph is a bit confusing. But yeah, in the beginning, the resistance is increasing, and then the resistance is supposed to be decreasing. However, it's shown a bit differently over here, but this was in your slides. That's why I put it over here. But yes, in the beginning, the resistance will increase. let's focus on this graph for now. This graph is super clear. At the beginning, the resistance will increase, and then the resistance will decrease because the radius or the total radius will increase. All right. Okay, guys, we spent so much time on this, like 45 minutes. Let's get going faster. So that was about radius. Any questions on the radius part? Because radius is important, guys. It's asked in the exams. It's asked in the exams. You need to know the ones that I've started, which is upper airways provide more resistance than lower airways. This is the important thing. Okay. Now, for example, if I have a tumor or a cancer growing in near the bronchi over here, okay, and the tumor is growing in such a way that it pushes the airways, making it a bit narrower and decreasing the resistance in the upper airways. Because in the upper airways already the resistance is high, okay, and there is a tumor that's growing, okay, and this tumor is going to further increase the resistance by decreasing the radius. Symptoms will show, but for example, if you check the resistance of the lungs, you will see that there is some problem over here in the upper airways because the resistance is extremely high. Okay? You get what I mean? In the upper airways, the resistance will be high and it can be seen in cases of diseases. But if you have a disease or a cancer growing in the periphery of the lung, where the total radius is high, the total radius is high. So, for example, if I have total radius as 1,000 in the periphery, all right, and I have a cancer that's growing and pushing against some of these bronchi and bronchiole, making the radius less, okay. However, still the effect on the total radius from 1000 will be like 950 only. However, there's still a cancer growing, okay? But when you check the resistance, it's not much of a big difference. It's from 1000 to 950, so I mean the radius is from 1000 to 950, so the resistance will not be much of a difference, okay? But when you go to the central bronchi, if you have a tumor that's growing and initially the radius was 5 and now the tumor that's growing is making the radius to 4, but because the radius over here is really small, the resistance is affected hugely, okay. So that is why we have something called a silent lung disease. Silent lung disease is when you have increased even though you have a problem in the radius of the peripheral lungs or the lower respiratory tract, it will not be shown in the resistance or the radius because of the huge amount of bronchi and bronchiole, all right. This is just another concept that I want to talk about. Okay, that's done. That's it for radius. Now let's come to the second part. So we talked about the factors affecting resistance, right? The first one was radius. We talked about radius. The main important key takeaway point that I want you guys to know is upper airways, high resistance. Lower airways, low resistance. All right? Now let's come to the second part, which is the volume. Now, talking about the volume of the lungs, we talked how the respiratory zone has high volume of air, right? Another important thing that I want to mention. Oh wait, how do I go back? Okay. Anyways, another important point which I want to mention was the volume in the respiratory zone is high, as I mentioned, and all of these bronchi and bronchioles, they are actually surrounded by all of this lung tissue. All right, all of these lung tissue surrounding them. When the lung expands, so as you can see, I've just drawn a picture over here. This is the alveoli, this is the alveoli, and over here you have a blood vessel which is present somewhere a bit in the side, and this is another bronchi which is present in the side, and this is how the lung looks like. It's not like a cake where everything is layered. Everything is actually mushed up together. All right. So when the lung expands, this brown thing, when the lung expands, the alveoli also expand, okay? They pull the bronchi and the blood vessel in all sides, okay? When they pull the bronchi and the blood vessel from all sides, what happens to the resistance inside? They pull it up, they pull it left, they pull it right, they pull it everywhere, stretching it and maybe like increasing in the volume inside, right? You get what I mean? Do you guys have any questions? Okay, wait. So as you can see over here, let me explain once more. So this is the lung, all right? The lung has alveoli, bronchi, bronchioles, and blood vessels all together. We're talking about how volume is affecting resistance. When there is increased volume, usually what happens is the resistance will also decrease. Okay? When volume increases, the resistance will decrease. Now let me show you how that happens. Okay? As you can see, this is the lung. Okay? This is the lung. Now, in the lung, oh wait, how do we? Now this is the lung. Now in the lung, when the lung is filled with air, it expands. When it expands, it also pulls together this bronchi and you get what I mean? So there is decreased resistance. So as the lung expands, the lung volume increases. When the lung volume increases, there is more outward pull. As the alveoli is pulling, it also pulls with itself, the bronchi also. So there is decreased resistance. Did you guys get this part? Is it a bit understandable? Or is it a bit confusing still? Okay, I'm assuming that you guys understood. Okay, that as the volume, the main important thing is as the volume increases, the resistance decreases. This is because the alveoli and the bronchi are glued together. As the alveoli pulls apart when the alveoli is filled with air and the lung volume increases and it's being pulled apart, both the bronchi and the extra alveolar blood vessels will be enlarging and thus resistance will decrease. All right. This is again another graph, the same thing. It shows the same thing. Here you have the lung volume. As we go to the right, the lung volume increases, and over here we have the resistance. We said as the lung volume increases, the resistance will decrease. Okay, so as the lung is being filled with air, you go from this is again the graph. Okay, for example, someone's taking a deep breath in, the graph moves from here all the way down. All right, and as the lung is filled with air, what happens to the resistance? It will decrease. So the least amount of resistance considered on the basis of volumes is going to be the total lung capacity. The total lung capacity is the volume in which the resistance to air is the lowest. All right, is the lowest. Okay, you got it. Why? Because the lung volume is high. Do you guys know what total lung capacity is? It is when I take a deep breath in, the amount of air that I have inside after a full forced inhalation is called a total lung capacity. At this time, the resistance to air is the lowest. All right? Did you guys get it? All good. I just want to ask, for example, if someone is having congenital small lungs, okay? If someone's having small lungs from birth, that means the volume of air that is inside their small lungs is going to be less. And so they will have a hard time breathing because of the increased resistance. They have a small lung, there's low volume, okay, which means increased resistance, and so because of that they will have a hard time breathing. So this is what happens in congenital small lungs. But the main important thing that you need to know is that the resistance is lowest in the total lung capacity because the volume is the highest over there. Now coming to the last part of the first lecture, which is the PCO2 and the resistance. As I mentioned before, we had factors. The first factor was radius, which was the important factor. The second factor was volume, and the third factor is the amount of carbon dioxide in the air. Subhanallah, it is such an interesting thing. For example, look at this lung over here. This lung over here, this bronchi is so large, and so it has lots of oxygen and air going in and coming out. Whereas this bronchi on the right side is actually occluded or like small. Okay, so when you think about small, this means that there's less air going in here and more air going in here. And subhanAllah, the body is made and designed in such a way that if there's more oxygen coming in and going out over here, how much will the partial pressure of carbon dioxide be over here? In this bronchi, which is large, so more air is coming in and going out. So there is going to be more gas exchange over here. If there's more gas exchange, there's going to be less carbon dioxide in the air over here because all of the carbon dioxide has already been exchanged. All right. So for a bigger bronchi over here, the partial pressure of carbon dioxide is decreased. And the body is now like, okay, my partial pressure of carbon dioxide is decreased over here. Does this mean that this bronchi is taking up too much of air, leaving no air for the other lung? So what happens is, subhanallah, the partial pressure of carbon dioxide, once it comes to know that the partial pressure of carbon dioxide is too low, this bronchi will actually constrict and decrease the radius, and this bronchi, which was having less airflow, will dilate, making sure that there's equal airflow everywhere. Did you guys get it? Did you guys get what happens? So as the partial pressure of carbon dioxide decreases, actually it's supposed to be decreases, it's a mistake over here. As the partial pressure of carbon dioxide decreases, okay, the bronchioles constrict, all right? The bronchioles over here will constrict. When they constrict, that means the resistance will increase, okay? The resistance increases because you do not want air over here right now. For this lung, you do not want air. It's already having enough air. You want air to go to the other lung. That is why this happens, to ensure that there is enough oxygen going both sides, all right? So what happens to the question over here? What happens to the resistance when the partial pressure of carbon dioxide decreases? Come on, guys, tell me in the chat box. What happens when the partial pressure of carbon dioxide decreases in the air? The resistance will increase. Why will the resistance increase? Because you have less carbon dioxide. This means that there's more air flowing over here. But you want to make sure that air is flowing equally everywhere. So I do not want such a big bronchi over here. I want to bronchoconstrict or increase the resistance for air over here so that more air goes everywhere else, right? So when the partial pressure of carbon dioxide decreases, the resistance will increase. This is, wait, let me just go here. This is supposed to be decreases, guys. It's supposed to be decreases, all right? Okay, coming to the next topic. Guys, do you want any breaks or do you want me to continue? This is just like a checkpoint. Hopefully you guys understood. Anything you guys have to clear about? Anything you want me to clear? You want me to, okay, explain what? The partial pressure of carbon dioxide, right? Is that what you want me to explain again? Reem? Okay. So again, the partial pressure of carbon dioxide. Okay, see, if I'm going to take a deep breath in and deep breath out, the main reason I want to breathe in and breathe out is to give oxygen to my body and to remove carbon dioxide. Am I right? In this lung, as you can see, one side of the bronchi is big or gigantic, which means more oxygen is going in here. And the other, but we want to ensure that there is equal amount of oxygen in both sides. For this, what happens is I want to make this bronchi or this airway small and this airway large. If I want to make this airway small, or I want less oxygen to go, or less air to go over here, that means in this part I want to make what, the resistance of the air increase. So what happens is in this part, the partial pressure of carbon dioxide is low. Why? Because you have more air coming in and going outside. More air is coming in and going outside, which means there is less carbon dioxide. When there's less carbon dioxide, the body will get triggered, saying that there's more air coming to this part and there's less air going to the other part. So what should we do? Let's increase the resistance over here so that air goes somewhere else where it's actually needed, so that we can maintain equal amount of airflow to every single part of the lung. That is why when there is decreased carbon dioxide pressure, when there is decreased or less carbon dioxide pressure coming to this part, and you do not want more air to come to this part, so you want to increase the resistance, right? So that is what happens. So when there is decreased carbon dioxide partial pressure, you want to increase the resistance. Did you guys get it? Who was it? Reem, did you get it? This is important to know. I hope you got it. Yay! More gas exchange, so as a result, there is more. Yeah, yes, Mariam. When there is more gas exchange, there is less carbon dioxide. That's exactly what I wanted to know. Okay. Do you guys want to drink some water or something? So that was the first lecture, guys. It's done. Now let's come to the second lecture. Okay. Before that, let's come to this one question, please, guys. Does anyone want to read this question? You want a 1 minute break? Should we do it before the question or after the question? I think we can do it after the question. Is that all right, Mariam? Let's do the question. Which of the following will decrease the airway resistance? A. Decrease lung volume. B. low partial pressure of carbon dioxide? C. Is it the respiratory gases? D. Histamine. E. Sympathetic nervous system. What do you guys think? So the question is asking something that should lower the airway resistance. What do you guys think is the answer? Hmm. E. Sympathetic nervous system causes bronchodilation, so more air volume and less resistance. Faya is thinking it's A. Decreased lung volume. Anyone else? All right, let me just go. So let's do one by one. Okay, let's start with the first option. So when the lung volume increases, okay, decreases. Let's talk about lung volume. When I talked about lung volume, we said that when the lung volume increases, the resistance will decrease actually. Yeah, so when the lung volume increases, the resistance will decrease because this is because the alveoli show you this is because the alveoli and the bronchi actually glued together. Yeah, yeah, they're opposites, exactly. The alveoli and the bronchi are glued to each other. Okay, so when the lung volume increases, this will also pull the bronchi, making it bigger and thus decreasing the resistance. Okay, so when there is in a decreased lung volume, the resistance will increase. This is what happens to people who are having congenital small lungs. Okay. Now coming to the second option is the low partial pressure of carbon dioxide. What we said about that? Will the low pressure of partial pressure of carbon dioxide decrease or increase resistance? We said before over here, for example, when there is a low partial pressure of carbon dioxide, means, yes, exactly, means it should increase. Very good, guys. So when there is less partial pressure of carbon dioxide, that means more gas exchange. We do not want air to come here now. We want to increase the resistance. Okay. What about the third one? Respiratory gases. What respiratory gases? I think this is a really a misnomer, sort of confusing option over here. Let's talk about this later on. I don't think it's the answer is respiratory gases because we know respiratory gases are not related to airway resistance, right? Is everyone agreeing with this fact? Respiratory gases do not affect the airway resistance. I think someone is asking, is it C then? I think Faya. Why do you think it was C? It's not C. Why? Because respiratory gases do not affect resistance in any way. It's D. Let's see D. So D is histamine. What's histamine? Histamine is some chemical. Okay. Let me go over here. Where was that? Yes. Histamine is a chemical, okay? These chemicals, again, act on the airway. However, what they do is that they will act on the smooth muscles, making them bronchoconstrict. If they bronchoconstrict, what will happen to the resistance? The resistance will increase. Yes, you're right. The resistance will increase. So in this question, they're asking if histamine will decrease the resistance. No, we know that histamine will cause bronchoconstriction. Why it makes them constrict? Very interesting. So you might learn this later on, but it's just a fact that these chemicals will go and act on the smooth muscles of the bronchi and decrease, how do I say this, and cause what you call more smooth muscle contraction. Who was listening? Okay, wait. Let me just explain why histamine does not causes bronchoconstriction. All right. So first, histamines are certain chemicals that are released in the body, and they cause, for a fact, they do cause bronchoconstriction. Do you need to know how they cause? No, you don't need to know that. Know that. Okay. Does that explain, Mariam? Because it will be too much of information if I tell you how histamine causes bronchoconstriction. It's just they are chemicals. All right. I hope that's okay. Yes, histamine is the same thing for allergies and inflammation, and histamine is released in asthma. That is why in asthma, when there's histamine, it leads to increased airway resistance and the person is not able to breathe properly. All right? What is Zaid saying? Decreased volume means decreased radius, increased resistance. Yes. Okay. Let's come to the last option, the sympathetic nervous system. What is sympathetic nervous system? It's a very important thing to know. Sympathetic nervous system releases epinephrine, norepinephrine. For example, you're going for a race, all right? Or you need to suddenly fight a lion. Do you want to breathe more or do you want to breathe less? Just tell me. When you want to fight a lion, do you want to breathe more or breathe less? In the sympathetic nervous system, you breathe more. So it causes dilation. Exactly. So it causes bronchodilation. When it causes bronchodilation, what happens to the airway resistance? It will decrease. Yes. So this is what is the answer for this question. Okay? So the answer for this question is E. Okay? Decrease causes more volume? Yeah, you can bring more air inside your lungs and more volume. You could say that. Okay, so guys, we have 1 minute break right now. For those who want to take a break, can take a break. For the others, you can ask me questions. Do you have any other questions, guys? Inshallah, we have to go over the next lecture quickly. We have less time. If it was increased airway resistance, let's see. If it was increased airway resistance, what increase? Increase. Oh, you're asking what would the answer be if if this question was asking what increased airway resistance? In that case, if the question would be, yeah, it would be A, it would be B, it would be D. If the question was asking about increased airway resistance, it could be A as well. Okay? Because when there's small lung volume, there's increased resistance. Okay? Or if there's less carbon dioxide partial pressure, okay, there's less carbon dioxide partial pressure means there's already more gas exchange going on in that place, so there is increased resistance. And the third thing, which is option D, histamine, again, when there's histamine release, that means, for example, in asthmatic patients there is increased resistance. So that is why the answer is E over here. Okay, guys, do you want any break or do you want to continue now? Yes, Zaid, you're right. You're absolutely right. Should we start with the second? Okay, I'm going to start. Bismillah. Now, the second lecture is talking about pulmonary functions. Bismillah. Now, how do we assess pulmonary functions? For assessing the function of the lung, we have a machine called spirometry, okay, in which you blow through this mouthpiece over here, and it checks two important things. First thing is checks the volume of how much air you blow outside, and second is it checks the flow rate, or how much air can you blow out in a specified time. Are you breathing out slow? Are you breathing out fast? That's practically what it says. It detects. Okay? So in this lecture, in this part of the session, we're going to see two things: the volume and the flow rate, and how we can assess lung functions based on that. Okay? For example, if there's a patient who comes to you and he or she is having a lung disease, you would want to know what lung disease they're having, right? So to detect that, you use the spirometry. And spirometry checks two things: the volume and the flow rate. Okay? Do you need to know what this looks like? No, I just added these extra pictures because they looked very interesting. Okay, now for spirometry, when the patient comes to you, what do? You give them this machine and you ask them to take a deep inhale, breathe all you can inside, and then take the mouthpiece, put it inside, and breathe deeply, exhale forcefully. Okay, so this is what happens. Now let's talk about two things. As I said, we're going to talk about two things: the volume and the flow rate. First, let's talk about the volume. Okay, volume assessment of pulmonary functions. First, Bismillah. Now, as I said, the patient is breathing in a lot and then forcefully exhaling outside. And then we have this machine that detects how much volume of air is the person breathing with time. So this is the time and this is the lung volume, okay? This is the lung volume in the sense how much volume is coming out of his lungs. That's what it's trying to say. Now, this is the time. As you can see over here in this part of the graph, this is when he was breathing normally, just like in and out, in and out. And then over here, it's the volume becomes super less, which is he exhaled fully, like leaves everything out. And then you ask him to take a deep breath inside, and then you can see that the volume of the lung shoots up to its maximum, which is the total lung capacity. And then you ask him to exhale forcefully and rapidly outside everything he can, and then he's exhaling right now over here in this line. All right, do you get this part? Okay. Now, when you if you try actually in your house or by yourself, if you inhale rapidly and exhale rapidly everything, and you try to release all of the air you have, the most amount of air that you exhale will be within the first second. And the amount of air that you exhale within the first second is called forced expiratory volume. Okay, FEV1. Forced because you're forcing it, expiratory because it happens in exhalation, and volume within 1 second. Okay, this is what FEV1 is. You need to know only three parameters. FEV1 is the first one. Forced expiratory volume in 1 second, which is the purplish shade over here. All right, did you guys get what FEV1 is? Is it good, or would you want me to explain again? Okay. Okay. Now let's talk about the second parameter, which is FVC, which is the forced vital capacity. All right. The forced vital capacity is the total amount of air you can get out of your lungs during the entire exhalation process. Okay. Which is the volume from you start exhalation till the end of exhalation, which is called the forced vital capacity. As you can see, the volume is represented from here till here. Let me just take this pen. Not sure if it's there. Okay. As you can see, this is the entire volume, forced vital capacity, which is the amount of volume of air that you can forcefully exhale completely. Okay? That's forced vital capacity. 80% in normal humans, 80% of the amount of air you can forcefully exhale, 80% of that is actually exhaled in the first second, which is what we talked about was the forced expiratory volume 1. Okay? You start exhaling, and in the first second, 80% of the volume is actually exhaled. And the rest of the time, you are exhaling slowly the rest of the volume. Did you guys get that part? The difference between FEV1 and FVC. Okay? And the last parameter that I want you guys to know is FEV1 FVC ratio, which is just divide this by this and you'll get a number. This is just to understand how much of air is actually being exhaled in the first second compared to the total amount of air that you have. Okay? Because someone can breathe out slowly in the first second, meaning they're only able to get out 50% of air in the first second, when actually a normal human can get 80% of air outside. You guys get it? So this is practically it. So to sum up, three things you need to know, parameters you need to know for volume detection is FEV1, which is the forcefully expiratory during exhalation, volume of air in 1 second, the first second, okay? Then you have the forced vital capacity, which is the total amount of air that you can get out of your lungs in the entire exhalation process. And then you have the ratio, all right? This, guys, is super important. Like, there's a gigantic star over here because there will be questions on this in the exam. It's super important, so please pay attention. If you have any questions, do ask, okay? Now, as you can see, this was what I explained before. Again, now, before we go into the important topics, let me talk to you about, let me put this over here. Yes, let me talk to you about the two different types of diseases, which is the obstructive disease. I don't know where it went. It's supposed to be written obstructive over here. We have the obstructive diseases and the restrictive diseases. Now, the obstructive diseases are diseases that affect the bronchi or the airway itself. So the airway is collapsed. As you can see over here, there is a problem in the airway. It's not allowing air to come in or go outside. So there is a problem in the airflow. However, the lung is expanding normally. Okay, this is what happens in obstructive diseases. If you consider the balloon, in obstructive diseases, this part of the balloon is what is affected, okay? However, the recoil or the way the lung can expand and relax is normal. The lung tissue itself is normal, but the bronchi is affected, okay? Because of which there is increased airway resistance. And this happens in asthma, obstructive diseases, other obstructive diseases, etc. Okay? So over here, what happens is when you're trying to exhale in the spirometry, air is not coming outside because the airway resistance is high. So their air cannot be exhaled. So more air is trapped inside the lungs. If you cannot exhale air, where is it going to go? It's going to stay in the lungs. So there's more air in the lungs. The second thing is the restrictive diseases. Okay? Now, the restrictive diseases have a problem in the lung parenchyma itself. The lung is not able to expand. So, when the lung is not able to expand, this means that there's a problem in this part of the balloon, all right? When the lung is not able to expand, this means that there is less air coming inside the lungs when you're inhaling. And if there's less air inside the lungs already, you'll be able to exhale air less, right? So in the exhale, in the spirometry, when you're exhaling, there will be less air coming outside. Why? Because there is less air inside in the first place for restrictive diseases. Do you get what I mean? There is decreased lung compliance, which is the air ability of the lung to expand. And there's increased recoil, which is the lung pushing back inside. So because of which there is a problem in air coming inside the lungs. There is no problem in the bronchi for restrictive diseases. Only a problem in air coming inside the lungs. So there's less air in the lungs in the first place. And so when you try to exhale, only less air comes outside. Did you guys get what I mean? Is obstructive and restrictive a bit okay for now? It looks a bit confusing at the beginning. Inshallah, you guys will get a hang of it. But for now, this is all you need to know for obstructive and restrictive. Did you guys get it? Yes, Mariam. Both have lower expiration. Yes. The first one, obstructive, have lower expiration because the bronchi is compressed. The bronchi is compressed and the airway resistance increases, so air is not able to go outside. Whereas in the second case, there is less air in the first place, so there is lower expiratory volume. Okay? All good? We can move on. So this is the graph that you saw in the slides. And inshallah, this is super important for the exam as well. Okay? This is how the normal looks like. So as you can see, I've put this man upside down. That's because the graph over here is upside down. So if you can see, initially, the graph was like this. However, over here, the graph is upside down. So I made the man upside down so you guys know what's happening. So over here, he's exhaling. The line that's going down is exhalation. Okay? So this is exhalation. Okay, so now let's start. Bismillah. The volume detection. Okay, important guys. This is super important. Please pay attention. And if you have any questions, just ask me. I will explain with you to you guys everything. Now, for volume detection, the first one, the volume, this is normal. So you start exhaling, forcefully exhale, and this is in the first second, this is how much you were able to exhale. And as the time went by, the forced vital capacity was this much. Okay, so these are just random numbers. FEV1, or the forced expiratory volume in 1 second, is 4, and the forced vital capacity is 5, and the ratio is about 80%. This is normal. In normal cases, in the first second, you will exhale 80% of the total exhaled volume, or the total forced vital capacity. Okay, this is in the first second. That was normal. Now let's come to obstructive diseases. In obstructive diseases, wait, let me show you over here. In obstructive diseases, okay? In obstructive diseases, what happens is there is a problem in air escaping from or air exhalation. Why? Because there is a problem in the airways. The resistance is high, okay? So air is not able to get out of the lungs during exhalation. If air is not able to get out of the lungs, what will happen to any volume in the expiration? Both will decrease. Any volume that you check in the expiratory volumes, all of them will decrease because air is not able to come outside. So FEV1 will decrease, or the amount of air that is exhaled in first second will decrease, and the total amount of air that you can ever exhale is also decreased, which is the forced vital capacity. All right. And when you check the ratio of the forced FEV1 to FVC, it is also decreased, which is less than 0.8%. Okay, which is also decreased. This is very important to know, guys. FEV1 over FVC for obstructive lung diseases, the ratio is decreased. Okay, the ratio is decreased. All good over here? Now, let's come to restrictive diseases, okay? So, for obstructive diseases, we talked about how air is not able to come out of the lungs because of the airway resistance. For restrictive diseases, there is less air inside in the first place. So, the amount of volume that can come amount of air that can come outside will also be less, okay? So, FEV1 and FVC both will what will they happen? They will decrease, okay? Why? Because you can only exhale less amount of air. However, the important point comes over here, which is the ratio of FEV1 to FVC. Okay, the ratio of FEV1 to FVC will be normal or increased. All right, how? I will explain you now. Let me just go behind over here to the, wait, where did this go? Yes, over here. As we said, in restrictive diseases, okay, in restrictive diseases, the lung recoil, the lung recoil is lost, okay, meaning the lung compliance and the recoil is messed up, and so the lung is not able to expand, and but however, there's no problem in contracting. So the lung can expand, but there's no problem in contracting, all right? When the lung expands, it's not able to expand enough, so there's less air inside the lung itself in the first place. Okay? But when it contracts, the amount that goes outside is less because there's less in the first place. However, the ratio of what is released, because there is no obstruction to airway coming outside, most of the air that comes outside, for example, 100 air comes outside in normal person, but in restrictive person, only 50 comes outside during exhalation because only 50 was inside the lungs. Okay, now when 50 comes outside in a restrictive lung, because the lung does not have a problem in the airways itself, most of the 80%, almost 80% of the air is exhaled in the first second. So the FEV1 over FVC ratio will be normal or sometimes even high. Okay, this is important to know. Did you guys get it a bit at least? Wait, where's my pen gone? Did you guys get it? Okay. Wait, where did I go? Yeah. Now coming back, why is it higher? You mean why is the thing higher? Yeah, I was trying to find my pen. Where did it go? Yeah, I found it. All right. Let me just tell you. Why is FEV1 FVC ratio high? I wish I had the thing. I don't know where it went. Okay. Okay. For example, if you consider this as the lungs, all right? Why is everything vanishing? Okay. Okay. So as you can see, Mariam, here is the lungs, okay? In restrictive diseases, there is a problem with the lung expanding. So the problem is with the lung expanding, okay? Yeah. Let's say, let's say this much air is there in the lungs, all right? This is the amount of air that's there in the lungs. When you're trying to exhale, okay, in restrictive diseases there is no problem in exhalation, the problem is inhalation. Okay, so in normal humans you have about 100 volume of air inside the lungs, so when you exhale you can exhale about 50 of it. Okay, but in restrictive diseases only 50 is there in the lungs. Okay, so when you exhale you'll be only able to exhale 25 of it. So in this case, for example, this, for example, let's say is the forced vital capacity. Okay, the forced vital capacity in normal persons is 50, which is normal. However, in restrictive disease, as you can see, it is the forced vital capacity is decreased. Why? Because there was less air in the first place. So that was that thing. But what about the ratio? The ratio is the amount of air that is exhaled in the first second. Okay, for this you need to have proper exhalation and patent airways. Okay, in restrictive diseases you do not have any problems with the airway itself. Okay, the airways are the airways are intact, and so when you want to exhale, the air goes outside quickly enough. Okay, that is why the FEV1 to FVC ratio, or the ratio, is normal or sometimes higher. Did you get, did you get that? In both cases, FEV1 and FVC will decrease. But in obstructive, FEV1 will decrease dramatically. Yes, and this is why there is decreased FEV1 to FVC ratio as well in obstructive diseases. Yes, Mariam, you are right. The person has a person who is having restrictive diseases has no issue with exhaling, but the only issue is with inhalation, and that is why they have less air in the inside the lungs, and so less air goes outside the lungs. There is no problem in exhalation. Okay. Now this is again another recap. This picture was there in your slide, so I put it over here for explaining. It's the same. All this time we were having the upside down graph. Now we're making the graph upright. The same thing. Okay. Now, one thing that I want to mention over here. is this is the green one is how it looks normally. As you can see, this is how much air is present in a normal person. When a normal person breathes in and breathes out, this is the amount of volume of air. So can you see how much volume is getting exhaled over here? This is the amount of volume that's getting exhaled. So over here you have lung volume, and over here you have the expiratory flow. Okay, the amount of lung volume that's exhaled in a normal person is this much. Can you see the width over here? This is how much a normal person can exhale. And the flow is also really high. That means normal person has no problem in inhalation, which is shown by the lung volume, and exhalation, which is shown by the expiratory flow. However, in obstructive diseases, the air is getting trapped inside the lungs because there is increased resistance in the airflow, right? Yeah, because of this, there is decreased air is not able to come outside, so you have this very weird slopey pattern. The air is trying to come outside and then somehow reaches the peak, and then the exhalation goes slowly, and this is how the person exhales forcefully in obstructive diseases. Again, why? As you can see, the FEV1 is decreased. Over here the FEV1 was this high. This was FEV1 for normal person, whereas for the FEV1 is only this much. All right, for obstructive diseases. For restrictive diseases, as you can see, the lung is not able to expand, but rather the lung wants to collapse and become small. So when you want to exhale, the lung exhalation becomes really fast. You get what I mean? The lung is contracting really fast because the lung does not want to become big. The lung just wants to collapse in restrictive diseases. That is why when you start exhalation, all of the lung starts collapsing and the air gushes outside. So FEV1, so the slope over here is really sharp. You get what I mean? It's like you start exhalation, it goes sharp, and then it goes down over here. Why it goes sharp is because because the lung is collapsing on itself in restrictive diseases. Did you guys get that? You don't need to know in so much details. The only detail that I want you to know from this slide is in obstructive diseases, okay? The airway resistance is the problem, because of which air is not able to come outside with the same speed that it used to come. So you can see this slopey fashion. It's coming like a dome. It's not going straight like the others. It's coming like a dome. So the slope is decreased. Whereas for restrictive diseases, okay, what happens is for restrictive diseases, what happens is the lung tries to collapse on itself. Okay, that's the problem. There is decreased compliance in restrictive diseases, right? So the lung tries to collapse on itself. So when you want to exhale, the lung will collapse, which will push air quickly outside the lungs when it's exhaling, and so you have this increased slope or the sharp peak. The peak over here. This is the dome or the slow peak. Okay, this is the decreased slope, and this is the sharp peak, which is the increased slope. You guys get an idea of the slopings? A bit, or not yet? Good? Any questions? Okay, so that was about the restrictive again. Mariam, I'll just come back to it later, inshallah. I will just finish this one and then I'll come to the restrictive and obstructive again, okay? This is just another diagram, which is a similar diagram, which shows the expired volume, which is the amount of volume that the person can exhale. So we said in obstructive diseases, the person is not able to exhale enough air because of airway resistance. Whereas in restrictive diseases, the person is not able to exhale enough air because there is less air inside in the first place, right? That is why you can see a normal person can exhale about 6 liters of air, whereas for a person who's having obstructive or restrictive diseases, he can only exhale about 2 to 3 to 4 liters of air. Okay, that's all you need to know from this slide. Now let me come back to the restrictive diseases and how it affects. I know it's a bit confusing. I'll come to this later on, Miriam. I'll come to this later on. So that was all about volume, guys. So we were doing volume all this time. So spirometry had two parts, right? The volume and the flow. So we're doing volume all this time and how the volume has three different components, which is the FEV1, FVC, and the ratio. Okay. We talked about how they changed and differed in obstructive versus restrictive diseases. Now let's come to the second part, which is the flow detection. This is a bit easier than the first one. Okay, so this was the graph that was given in your slides. I'll come back to this later. However, in your for the detection of flow in spirometry, you have something called as PEFR, which is the peak expiratory flow rate. Okay, which is at what point of time is a maximum amount or the speed of air coming outside during exhalation the highest. Okay, so it would be this point in the graph. Okay, it's the same graph, guys. The same thing that we've been seeing so far. It's the same thing, but however, this point, which is the peak, is called as peak expiratory flow rate, which is the maximum amount of speed with which the air comes outside. Okay, it's just about speed of air and the amount of air. Okay, that was peak expiratory flow rate. We have other things, so let me just talk about peak expiratory flow rate. Now, so in normal person, a person breathes, inhales, and then exhales fully, right? When they start exhaling, in the first second, the speed or and the amount of air that comes outside is super high, and this is how it is for a normal person. The peak expiratory flow rate is really high. Okay, this is a normal person, and usually it happens within the first second because we said in the first second, within the first second, that is when the most amount and the most speed and the most amount of air comes outside. Okay, and this depends on the patient's effort to exhale. For example, I'm exhaling with my maximum effort, then the peak expiratory flow rate is going to shoot up like this. However, if I'm not going to put my maximum effort, then the peak expiratory flow rate is going to just stop over here and then come back down. Did you guys get that? That's what's shown over here. When I put moderate effort, this is how much the peak expiratory flow rate can go. Okay? My expiratory flow rate, the maximum, is only going to reach up till here. Whereas if I put my full effort, it's going to reach high. So the peak expiratory flow rate, okay, the peak expiratory flow rate is dependent on your effort or how much effort you're putting into exhaling. All right. So it is dependent on. Did you guys get that? I think it's a bit easy to understand this. Okay. Whereas in obstructive diseases, in which the air is not able to come outside, the peak expiratory flow rate will decrease naturally. The amount and speed of air that you can get outside is going to become low. Okay, but how low? How will the slope look like? The slope will be at, I mean, sorry, how will the graph look like? The graph will be sloped and the slope will decrease, right? Because you're not able to get air outside quickly. However, the flow will also decrease. You know, we said the flow is dependent on time and volume, right? There's decreased volume coming outside and the time is also slow, all right? So this is what makes the peak expiratory flow rate less in obstructive diseases. Whereas in restrictive diseases, again, the peak expiratory flow rate decreases. But why? Why does the peak expiratory flow rate decrease? That's because you're having less volume of air inside the lungs. When there's less volume of air inside the lungs, the amount of volume that you can get outside is going to be less. So the flow is going to be less, right? So the peak expiratory flow is also going to be less or decreased. This happens in restrictive. However, the slope is going to increase, meaning it's going to shoot up within 1 second you can get a lot of air outside. Okay, however, the flow or the amount of air that's coming outside is less compared to normal. Did you guys get this? Do you want me to repeat it again? Okay, I'll explain it again in some time, inshallah. Let me just tell you. So that was peak expiratory flow rate. We talked about peak expiratory flow rate, which is the peak intensity or the maximum you can get of the force or the speed of air during exhalation. It usually happens in the first second and it is the peak of this graph, all right? It is dependent on the amount of effort you put, okay? The amount of effort you put decides how high the peak expiratory flow rate can become. In disease states like obstructive diseases and restrictive diseases, the peak expiratory flow rate will decrease. In obstructive diseases, the peak expiratory flow rate will decrease. Why? Because the air is not able to get outside because of the constricted or the restricted air. Whereas in restrictive diseases, the lung is not having enough air in the first place. That is why the peak expiratory flow rate will decrease, okay? Or the amount of air you can get outside will decrease. However, for the slope, now we come to the slope in obstructive diseases, okay? The slope in obstructive diseases will decrease. Why? Because it takes time for the air to come from the lungs to outside because of the obstructed airways. Whereas for restrictive diseases, the slope will increase because the lung is trying to collapse and push the air outside. Okay? So the slope will increase. It's going to shoot up and then come down. Whereas for obstructive, it's going to take time to go up and then takes time to come down. Did you guys get it? Coming to the next topic, which was FEF or the forced expiratory flow. This is not that important, just one point from this you need to know, but I'll explain it to you guys so that you guys can get the concept. So, forced expiratory flow, okay, is the amount of air. Sorry, guys. Forced expiratory flow is the time in which you can have. How do I explain this? For example, you started inhaling, then you started exhaling, okay? In the first in some time of your exhalation, okay, you've exhaled only 25% of the air, and more 75% of what you need to exhale is remaining, okay? That's called FEF 75. More 75 is remaining, okay? More 75% of what you can exhale is remaining. This is called forced expiratory flow in 75%. All right? It's a bit confusing, but I'll explain it once more. Whereas if you started exhaling, if you inhaled fully, and then you started exhaling, okay, and you could exhale 100 air, 100 volume of air, okay. At the 50, for example, when you've exhaled 50 and 50 is remaining, that's called FEF 50, forced expiratory flow 50, okay. And when you're exhaling and only 25% is remaining, that's called FEF 25, okay. This is just different points. All you need to know is that these are different points in your exhalation process, okay? In the exhalation process, these are just three different points. FEF 75, 50, and 25, okay? 75 is when 75% of the vital capacity or how much you can totally exhale is remaining. 50 is when 50% of what you can totally exhale is remaining. And 25 is when 25% is remaining of what you can totally exhale, all right? This is just some terms. But what you need to know from this is FEF 25, which is forced expiratory flow of when only 25% of vital capacity is remaining, is effort independent region. Effort independent means even if you blow so hard in exhalation, when only 25% of air is remaining that needs to come outside, whatever force you put, the flow is going to be the same. The flow is going to be the same no matter what force you put. For example, over here, I start inhaling and then I exhale maximally. Okay, I exhale with all my force, but when 25% of it is of the remaining, what I can exhale is remaining. Even if I put the amount of, even if I put like so much force, the flow rate or the amount of air that can come outside is the same. The flow is going to be the same. And whether I put moderate effort or minimal effort, like I just breathe normally, still whatever I can get out during the last 25% of my exhalation process, it's not going to be affected by how much force I had put at the beginning. You could try this yourself. Like you could actually like take a deep breath in, and then forcefully exhale, and at the end you can see how much air is coming outside. It will be the same as how much air would come outside at the end of normal expiration. You get what I mean? That's all that it is. It's just a simple concept which says that at the end of any sort of exhalation, whether it's forced or not forced, it is independent of what effort you put at the beginning of the exhalation, all right? You can exhale it. You can exhale it. Okay? Forced vital capacity is the amount of air you can totally exhale. But the last part of that vital capacity, okay, the last few amounts of air that you want to exhale, even if I put so much effort at the beginning, or if I was just normally breathing, the last part of air comes with the same amount of flow, okay, or the same amount of speed. Just as I had, for example, I take you can try this right now. You take a deep breath in, okay, and then blow out. And then at the end of your breathe exhalation, see how much air you can get outside. It would be the same as how much air I can get outside, or the flow of my air when I'm breathing normally or exhaling normally. That's what it means. You can exhale it though. Okay? Okay, guys, so let's come to the important topic now. This one is super important, which is the summary of the lecture. We're coming to the end almost. Nice question, Mariam. I'm not talking about the amount of what we exhale. It's about the flow or the speed of air that's coming outside. You get what I mean? It's about the speed of air that I can get outside, which is in the effort independent region. We're talking about forced expiratory flow, not amount. We're not talking about amount. We're talking about the flow or the speed or the amount, the flow of air that's coming outside. So, no matter how hard we try, at the end of my exhalation, the flow is going to be the same as how I would have done when I was just exhaling normally. That's what it means. How fast can you exhale the last 25%? How fast you can, the speed, how fast can you exhale the last 25%? For example, let's consider the last 25%, okay? We're talking about that now. When I put my complete effort of exhalation, in the last 25%, my speed will be 5, okay? And if I'm just going to breathe normally, the last 25% for normal breathing, the speed will still be 5. It's not dependent on how much effort I put. This is what it means. I hope you got it. Okay? Tamam. Let's come to the summary, guys. This is important, and I want all of you to focus on this. This is where the questions are going to come from in the exam. Please focus on this right now. Let's talk about obstructive diseases and restrictive diseases. Obstructive diseases have a problem in the airways. The airways are restricted. You cannot get air outside the lungs during exhalation. That was obstructive. For restrictive, there is a problem in the lung compliance and the lung recoil, meaning the lung is not able to inflate. All right, the lung is not able to inflate with air, and thus it has less air in the lungs. When it has less air in the lungs, when you try to exhale, there will be less air coming outside. Now, what happens to the forced expiratory volume in first second for obstructive diseases? Now, let's first do obstructive diseases. All right, everyone, I want you to be in your chat box, and I want you guys to answer. What happens to the obstructive diseases in the for FEV1 for obstructive diseases? Sorry, what do you guys think? I want you to say is increase or decrease. Decrease. Very good. Why? Because there is a problem in the airways. You're not able to get air outside, so FEV1 will decrease. Very good. What about FVC? Forced vital capacity, the total amount of air you can exhale. Will it be? It will decrease. Very good, guys. It will decrease. Okay. What about the ratio? FEV1 to FVC ratio. What will happen to the ratio, guys? For obstructive diseases. It will, yes, it will decrease. Very good. Why will it decrease? Because you're not able to exhale the air because of the occluded or the restricted airways. The restricted airways are not allowing you to exhale as much air as you want in the first second. So the FEV1 and FEVC ratio will be less and decreased or less than 80%. There's no decreased, okay? It will be decreased. This is the part that they catch you in exam, okay? The FEV1 to FVC ratio. What about the peak expiratory flow rate? How fast the speed or the maximum flow that you can get? What happens to that? Will it increase or will it decrease? It will decrease. Very good. What about FEF or the forced expiratory flow rate at 75%, 50%, and 25%? What will happen to that? I think I not explained, but this is making a sense. It will decrease as well. Why? Why will it decrease? Because everything is less. The amount of air that you can get outside is less. The speed is less. So then it will affect the forced expiratory flow rate as well. What about the slope, guys? This is another important thing. What about the slope for obstructive diseases? Is it normal, increased, or decreased? What? It will be decreased. Very important. The slope will be decreased and it will go like a dome instead of shooting up and coming down. Okay? This is important to know. Now, talking about restrictive diseases, okay? What happens to the FEV1 in restrictive diseases? Yes, Mariam. You're right. You're right. Okay. Let's talk about restrictive diseases now. Okay. FEV1 will decrease. You guys are right. Okay. What about FVC? The forced vital capacity. Because there is less oxygen. Yes, very good. It will decrease. Because there is less volume of air inside the lungs, there will be less coming outside. Yes, Zaid. Very good. Yes, FEV1 FVC ratio will either be normal or increase. Either be normal or increase. Very good, guys. Very good. Amazing, mashallah. What about the peak expiratory flow rate? What happens to that? What happens to the peak expiratory flow rate? It will decrease. Tamam, very good. It will decrease. Very good. What about the FEF, forced expiratory flows rates for 75, 50, and 25%? What happens to those? Because the peak expiratory flow rate, the amount of air you can get outside, will decrease. Very good. Very good. What about the slope for the restrictive diseases? What happens to the slope? Increase. Very good, guys. I'm so happy, honestly. I'm so happy. Very good, mashallah. Very good. Inshallah, you guys will ace this question in the exam, inshallah. So that was the main part of it. Now let's quickly go over the dynamic compression of airways. It's a topic that I really want to draw. So let me just get my drawing stuff outside. Give me a minute. Mhm. Okay. So let's talk. Where did I go? Yes. Okay. Now, dynamic compression of airways, subhanallah, is a very interesting question. Remind us why. You mean the slope, right? The slope increases because the lung is trying to collapse. The lung wants to collapse or close, or like, yeah, the lung wants to collapse. When the lung wants to collapse, it will aid in exhalation, right? So it will be easier for you to for the restrictive lung to exhale. So more air is pushed out in the first second. So the slope or the slope will go up quickly and then come down slowly. Okay, that's what it means. Okay, now let's come to the dynamic compression of the airways. Now, dynamic compression of the airways is a topic, okay, that depends on the transmural pressure or the pressure across the airway wall. This one. Oops, what happened? Okay. Pressure across the airway wall itself, okay? And we talked about the transmural pressure depends on the expiratory muscles, it depends on the lung alveolar pressure, and it depends on the lung recoil, okay? Now, inside the airways, you have the airway pressure or the PAW, okay, which is the airway pressure. And outside, you have the expiratory, the muscles of expiration, okay, which is the which is the what you call the alveolar, no, not alveolar, it's called the pleural pressure, which is the pressure made by the expiratory muscles itself, okay. Wait, how do I put this? Okay. Now, for this, what I want you to know. Wait, how do I get this out? Yeah. For this, what I want you to know is what happens in normal cases. In normal cases, let me draw this out. In normal cases, I don't want you to go into details of this because it's a bit confusing. However, I will tell you what you need to know. So in normal cases, okay, this is the lung. As you can see over here, this is the lung. So this is the lung, okay? You have the transmural pressure. In normal cases, you have the lung recoil force, that this is the lung recoil force, all right, which is trying to push everything inside and collapse. But you have something pulling outside, which is going to be two things, which is the alveolar pressure or the pressure of air inside the walls, and also the pressure made by the muscles of expiration. Now, yes, in normal cases, we're going to talk about two pressures now, the pleural pressure and the alveolar pressure. Okay, the airway pressure. So airway pressure is over here, whereas the pleural pressure is over here. Okay, pleural pressure. Never mind. Now, normally the airway pressure is not changed at all. The only thing that you can change while breathing is the pleural pressure. By forcefully exhaling or forcefully inhaling, you can change the pleural pressure or the pressure that's present surrounding the alveolar, the bronchi and the alveoli, all right? So in normal cases, the airway pressure is normal. However, the pleural pressure can decrease and increase and so on. All right, this is what happens. Now, for example, the pressure over here, when you're starting to exhale, the pressure over here, how do I say this? The pressure, wait, what happened? Oh, yeah. The pressure over here is high. All right, over here, it's high. And once you move along the airways, the pressure is going to decrease, which makes sense. The pressure is going to be highest when you start pressing the balloon, and then it's going to decrease along the way or along the airway. All right. Now, in normal cases, the transmural pressure is such in such a way that you have a point called as equal pressure point. This is called as the EPP, which is the equal pressure point. Now, this equal pressure point is the place where the pleural pressure and the alveolar pressure cancel each other. Okay, so the transmural pressure becomes zero. After that, the pleural pressure becomes really low. How can I say this? For example, over here, the expiratory muscles are keeping a force of 100. Over here, the expiratory muscles are keeping a force of 50. And inside, you have a constant pressure of 50. Okay? In this point, 50 is inside, 50 is outside. The airway is still patent. The airway is still patent, and air can flow. However, after this point, the pleural pressure will start decreasing. So it will become something like 40, right? But over here, you still have 50. So inside pressure is more compared to the outward pressure. So this makes the airways get compressed. Okay, this makes the airways get compressed, and this happens normally. However, the point in which the equal pressure point happens is actually in the place of cartilaginous bronchi. You know the cartilaginous bronchi, right? Not every bronchi has cartilage. The cartilage is there to make sure that everything is patent all the time. Okay? In normal cases, the equal pressure point comes at the level of the cartilage. Okay? When it comes at the level of the cartilage, even though the inward pressure of the lung recoil is high, the bronchi still does not collapse and compress and get occluded because of the cartilage. The cartilage is stopping it. Okay, this is normally. So in normal cases, what I want you to know from here is that there is something called as equal pressure point. Equal pressure point is the place where the inward or the occluding or the lung recoil pressure, which is the inward pressure, the pressure that tries to collapse the bronchi, and the pressure that is trying to keep the bronchi patent or open, they both cancel each other at a point called equal pressure point. After this point, usually you would expect the airways to get collapsed. Why? Because the inward pressure will be high in that case. However, this doesn't happen because in that case you will have the cartilage. Okay, the cartilage will be keeping it patent. All right. So this was all about the normal thing. You don't need to know much details, just about equal pressure point, and that's mainly it. What you need to know. Okay. That was all about normal, guys. Now let's talk about one more important thing, which is the restrictive disease. In restrictive disease, okay? Oh, wait, something's happening in the chat. Let me see. What happens when it reaches? Did this get cleared, Mariam? What happens when it reaches equal pressure points? I did not see this. I just saw this now. Did this get cleared for you? Okay, I'll just explain this and then come back to that. So in restrictive diseases, as we said, I mean to airflow. What happens to airflow when okay. Um, Let me see. Let me go back. Honestly. Yalla. Okay. In normal cases, let me explain this again. In normal cases, okay, this is our airways, okay? From this point you have cartilage. From this point you have cartilage. Normally the equal pressure point happens over here. And this is when the transmural pressure becomes zero. And after which you would expect in these parts you would expect the invert pressure to be so high to actually collapse the bronchi. But the bronchi doesn't collapse because the cartilage is keeping it patent. All right. So this airflow will still happen. The air will flow through this. However, in these parts of the these parts of the airways, the what do you call this as? Got the name suddenly. Yeah, the pressure of the pleura is more than the pressure that is inside, the collapsing pressure or the pressure of the lung recoil. So this keeps the airway patent, right? But as you keep going across, up the bronchi tree, we said that the pleural pressure will fall down, right? We said the pleural pressure falls down. So as it falls down, there reaches a point where the pleural pressure is no longer able to keep the airway patent, all right? And so this will lead to collapse. You would expect that. But this does not happen. Why? Because of the cartilage, all right? So that was about the normal case. Now, coming to restrictive diseases. In restrictive diseases, we said in restrictive diseases that, sorry guys, in restrictive disease, we said that there's a problem in the lung recoil or the lung compliance. Okay, the lung is not compliant and the lung just wants to collapse and become a big mush. Okay, so what happens is the lung is not able to expand, right? So when the lung is not able to expand, what happens to the pleural pressure? What do you think would happen to the pleural pressure if the lung is not able to expand? The lung normally is supposed to expand, causing the pleural pressure to go high, making sure that the airway is patent. But in restrictive diseases, the lung is not able to expand. Okay? When the lung is not able to expand, what will happen to the pleural pressure? It will decrease. Yes, absolutely right. It will decrease rapidly. Okay? It will start at this point and decrease rapidly. Whereas in normal cases, it was supposed to start at this point and decrease slowly. Okay? It will decrease rapidly because you're not able to generate enough pleural pressure, right? In restrictive diseases. So how will this affect? How will this affect the person's breathing? We said the alveoli is over here, and this is the bronchi, and the cartilage actually starts from here. In normal cases, the equal pressure point was over here, but in this case, the equal pressure point is over here, at a place which does not have cartilage. In that case, what will you expect? Now, you would expect the bronchi to collapse from here onwards. From here onwards, the bronchi is going to collapse. So when the person is exhaling, okay, and the pleural pressure which was supposed to be high but is not high now falls very rapidly, pushing the equal pressure point closer to a place that does not have cartilage. Now you would say that the airways are compressed and occluded, and this will not allow oxygen or air to come outside easily. Did you get what I mean? This is called dynamic compression of airways, and this is like a problem that happens. Did you get it, guys? Did you get what happens to the equal pressure point in restrictive diseases? In restrictive diseases, in restrictive diseases, the air, the lung is not able to expand and generate enough pleural pressure. So the pleural pressure is less and decreases rapidly, which makes the equal pressure point to come to a place that does not have cartilage. Now the cartilage is no more there to help air come outside. So the air initially would come outside, but when the pleural pressure decreases, which is at the later stages of expiration, when the pleural pressure is really low, all the airways are like collapsed, and the person is not able to get outside air. Okay? Even air going on, I did not get you, Mariam. Mariam? In. Yeah, the air goes in. This is during exhalation. I'm talking about this is exhalation. So air is supposed to go outside. The air initially it goes outside, but once the pleural pressure decreases so much, it makes what you call the it makes the what you call I forgot the name suddenly. Yeah, it makes the equal pressure point to come closer. Okay, I'll probably explain this once more, but this is the main thing. All right. Now, what was this all about was for this one important topic called as lip pursed breathing. Okay, this lip pursed breathing is important. Yes, you're right, Mariam. There is an issue with inhalation. So in restrictive diseases, two things are lost. First is the recoil. Okay, there is increased recoil, and there's a problem with the compliance. All right, the compliance is decreased. When the compliance decreases, this means there's a problem in inhalation. Okay, when the compliance is decreased, there's a problem in inhalation, and the lungs are not able to expand. All right, but when there's increased recoil, which is what I said, when there's increased recoil, and over here, this compliance, the decreased compliance means the lung is not able to expand properly. When the lung is not able to expand properly, this will affect the pleural pressure, all right? So this will lead to decreased pleural pressure. And when there is increased recoil, this means the lung wants to collapse. Lung wants to collapse, okay? So if you think about it, the lung wants to collapse. There is decreased pleural pressure, which is keeping it outside. So this makes what you call the airway to collapse at a place earlier than the cartilage. So the equal pressure point will shift. Okay. Now, in order to prevent this from happening, in order to prevent this from happening, people who have restrictive diseases like emphysema, which is a type of disease, type of restrictive disease, what they do is that they have something called lip pursed breathing, which is they, like keep their lips really tight, but with a small hole. What happens is, in that case, if this is their mouth, they're making it really narrow over here, okay? Which means the pressure over here is the pressure at this part, and therefore the pressure all inside is going to be high. So the pressure inside the airways, the PAW, okay, the PAW, the pressure inside the airways is going to increase, all right? When the pressure, let me just remove this. When the pressure inside the airways is going to increase a bit, this will make sure that the airway is remaining patent. Did you guys get that? Why lip pursed breathing helps in making sure that the airways are remaining open for people who are having restrictive diseases. Should I explain once more? Just once more? Let me explain once more. So the person who's having restrictive disease, as we said, has airway collapse in a place that is before the cartilage, and so they're not able to get air outside. Okay, to compensate this and to make sure that this doesn't happen, people who are having restrictive disease like emphysema, okay, what they will do is that they will have lip pursed breathing, which is like making your lips really small with just a small air coming small place for air to come outside. Only a small place for air to come outside. Because the air is now going through a smaller hole, this means there is increased pressure over here. There's increased pressure. So there's increased pressure, and this increased pressure makes sure that even though the recoil force is high, even though the lung is trying to compress on itself, the increased pressure inside the airways now, because the person is breathing with a pursed lip, will make sure that the airways are remaining patent. Did you guys get that? Yes, the issue is all to do over here is in this case of compression of the airways is to do with pressure, not the volume, not the flow. The volume and the flow is also affected, but we're talking about the way in which restrictive diseases will have compression of the airways. All right? Did you get that, Zaid? So in restrictive diseases, you have compression of airways, which happens because there is a problem in the pressures inside the transmural pressure inside the lungs. Again, the lungs want in restrictive disease, the lungs want to collapse. Again, because of the decrease in compliance, there is a problem in inhalation. This is the part. This is the part that Zaid was talking about. This is the part that affects the volume and the flow. All right. Okay, I'm not able to write that. However, all of this will cause the what you call will cause the compression of the airways. Okay, did you guys get it? Now, how will this be asked be in the will be asked in the exam? They won't go into details. All that they will ask is lip pursed breathing. Lip pursed breathing is for what? Mainly, you need to know for what disease lip pursed breathing is used. It's used for restrictive diseases. All right, it's used for restrictive diseases like emphysema, lip pursed breathing, and it is because to ensure that the airways remain patent. All right, that's it. Because the equal pressure point is shifted. That's all that you need to know. Did you guys get that? Should we go over the quizzes now? Quickly. So let me know, guys, if you guys understood it. This session is going a bit too long. Didn't expect it to go this long. Oh, you guys are reading the question, great. The maximum expiratory flow volume curves are shown in this diagram of a 57-year-old man and who's having shortness of breath. Which of the following disorders is he most likely to have? Isn't emphysema obstructive, not restrictive? Interesting, Riham. Emphysema is restrictive. Wait, emphysema? Emphysema is restrictive disease. It's not obstructive. Did that clearly harm for you? What do you guys think is the answer for this? Now, coming to the graph over here, you can see the slope of this curve is really sharp. It goes up and it down quickly, right? So the slope is high, or the slope is like sharp. So what would you suggest? What do you think? Asbestosis, kyphosis, scoliosis, silicosis, tuberculosis, emphysema. So the answer over here is emphysema, which is again a restrictive disease. And restrictive diseases show the slope over here is going up and going down. And you can see over here that the expiratory peak expiratory flow, which is the peak over here, is low. There is less air coming outside, and yeah, that's mainly it. This is what you can see over here. This is an easy question, guys. Okay. What about this one? I'll come to your question later. Just give me some time, Ibrahim. Let's just go over this quiz for now. Compared to a normal healthy person, how do the total lung capacity and the maximal expiratory flow change in a person who's having restrictive lung diseases? So they said that the person having restrictive lung disease, okay? What happens to the total lung capacity? So when if we said in restrictive lung diseases, they're not able to inhale because the lung is not able to expand. So what would you think would happen to the total lung capacity? Will it increase or decrease? It will decrease. So using that itself, we can kick out A and C because it says it increases. However, that's not the case, okay? Now we have two options, B and D, okay? B and D. What happens to the maximal expiratory flow rate? The maximal expiratory flow rate will also decrease, right? Because the person is not able to, this was again because of the dynamic compression of the airways. We said the dynamic compression of the airways in which the equal pressure point comes earlier, and so the expiration will be affected, right? So the person will not be able to expire as much as they want, or they exhale as much as they want, because the airways are compressed now. Does that make sense? So the answer here will be B. Very good, Faya. Hope I'm telling your name right. Does then anyone want me to explain this again? This question. Is this alright? Did you guys get it? It's good? Okay. So coming back to Ibrahim. First of all, just know this, guys, that emphysema is a restrictive lung disease, okay? Now, in restrictive lung diseases, okay, in restrictive lung diseases, you have the main problem is in a lung expansion, or the lung being able to get filled with air. There's a problem in that, all right? Because there's a problem in the lung expansion, there is less air coming inside the lungs, okay? When there's less air coming inside the lungs, in the slides it's written obstructive. Really? For emphysema? Hmm. Really? Yeah. Oh wait. Hmm. Did I make a mistake then? If that's the case, maybe I think I made a mistake, guys. Whatever I explained about restrictive lung disease is correct, but the only mistake that I would have been making is Pretend the examples are somewhat restrictive disease. Yeah, I think I made a problem over here. Give me 1 second, let me just confirm this. I found a mistake which I did, guys. I'm super sorry. So the problem is this. Apparently, it's not restrictive diseases. It's apparently obstructive. I made a big mistake, guys. It's supposed to be obstructive diseases, which makes sense. Ibrahim was right then. So what Ibrahim was saying was how can, but this happens in restrictive disease as well. But you use it for both diseases actually. Okay, guys, let's come back all over then. For obstructive diseases, yeah, for obstructive diseases, as we said, there's a problem in the airway resistance. Flip all of it. You could, yeah, you could say the entire thing, the concept is correct, okay? The lip purse breathing, why we do it, why the person does it is correct. It's to ensure that the airway is patent, right? To ensure that the airway is patent. However, it happens in emphysema, which is an obstructive disease. Okay, so emphysema means lip purse breathing. Okay, and emphysema is an obstructive disease. Thank you so much for correcting whoever corrected it. MashaAllah, may you get high grades. But yes, emphysema is an obstructive disease. All right, emphysema is an obstructive disease. I just want you guys to understand the obstructive disease, lip purse breathing, and all right. Let me just erase all of this. Okay. Yes, I will compare. I wish I had a nice slide, but okay. Let's start with obstructive diseases. Okay. Obstructive diseases is a problem in, as you guys said, there's a problem in the airway. Okay. The airway resistance is high. If the airway resistance is high, this means there's the airways are getting compressed. Airways are compressed. All right. Now, when the airways are compressed, you want the airways to, when the airways are compressed, you want the airways to, stay patent, right? Because of which you do the lip pursed breathing. When the lip pursed breathing is there, you increase the pressure inside, so there's increased pressure over here. When there's increased pressure inside the airways, this will make sure that the airways are patent, okay? If the airways are patent, this will lead to, this will make breathing easier for the person, okay? So the person will have pursed lips, lip pursed breathing. Did this make any sense, guys? Um, what would you like me to explain, Mariam? Any specific part you want me to explain? This was for obstructive diseases, all right? This was for obstructive diseases. For restrictive diseases, um, you again, the restrictive disease was what I explained before. Emphysema and fibrosis again. Okay. So for restrictive diseases, okay, there's a problem in the lung compliance. The compliance will decrease. Okay, compliance decreases. When the compliance decreases, this means there is less lung inflation, okay, meaning the total lung volume will decrease, all right? And then you have another thing, which is increased recoil force. The increased recoil force is the one that is also trying to collapse everything together. And this will lead to the sharp increase and decrease of the slope. This is basically what you need to know. So for obstructive lung diseases, they're not able to get the air outside. Whereas for restrictive diseases, they're not able to get their air inside mainly. Okay. For obstructive diseases, since they cannot get their air outside because of occlusion or compression of the airways, they do what you call lip pursed breathing. And the lip pursed breathing increases the airway pressure, in the pressure inside the airways, which makes sure it's a bit patent, and so they will have slowed exhalation, but they'll be able to exhale properly. Did you get it? Is it a bit okay? All right. Did you guys understand it? Do you need to know all of the tiny details over here? No. Okay? But it's the main thing is to understand the concept. All right? So for lip pursed breathing, it is used in emphysema, which is an obstructive disease. Thank you to someone who explained it to me. So obstructive disease in emphysema, which is an obstructive disease, you will have lip pursed breathing to ensure that their airways remain patent. All right? Any other questions you guys have? Anything you want me to explain? Anything else? Any doubts? I think that's the end of our session. Let me just see if we have any more quizzes. Oh, did we do this? Yeah, we did this. The answer was B. Do you have any other questions, guys? Anything else? Isn't lip pulse breathing to get more oxygen in your lungs? When you want to get more oxygen, just imagine if you want to breathe more, like you want more oxygen inside your lungs, would you keep your mouth a bit more open or a bit more closed, just like that? So usually when you want more oxygen inside, your lips or your mouth will be wide, like a big mouth. But when you want to exhale, for example, a person who's having obstructive lung diseases and there is occlusion over here, for example, okay, because the airways are not able to remain patent. In that case, the person will do what you call lip pursed breathing. Over here, their lips are like pursed, which is like closed enough, and so this will increase the airway pressure inside. The increase in airway pressure will keep the airway patent, and so you'll be able to exhale, not for inhalation. There is no problem in inhalation. Why? The problem is not in obstructive disease, there is no problem in inhalation, correct? There's a problem only in exhalation. So the air can come in, but when it wants to go outside, that's where the problem comes. When the air wants to go outside, the lung what do you call, the airways get compressed because of the decreased in pleural pressure, because the pleural pressure decreases quickly. The one that we said, pleural pressure and the airway pressure. Airway pressure remains same, but the pleural pressure decreases quickly, whereas in normal cases it would decrease slowly. Did you guys get it? Did you understand, Mariam? What about the others? Thank you so much for staying for so long for the session, guys. I hope it was beneficial. Inshallah, you can scan the QR code for the feedback. And if you have any other questions, you can text me, email me, anything you like. I hope the session was beneficial. Thank you so much. Assalamu alaikum. How do I stop this? Oh, wait, my camera was weird all this time. Thank you so much, guys, for joining.